The first case, we should go in a stepwise approach, systematic approach for any critical case, especially in acid-base disturbances. Step 1 is, should know whether there is acidemia or alkalemia. If it is less than 7.35, acidemia. More than 7.45, alkalemia. That is step 1. Step 2 is primary acid-base disturbance, whether it is pure metabolic acidosis or alkalosis or respiratory acidosis or alkalosis. Step 2 is we should establish the primary cause for that acid-base disturbance or metabolic or respiratory process. That is step 2. Step 3 is compensation. If it is metabolic acidosis case, if the primary cause is metabolic acidosis, what is the respiratory compensation? If the primary cause is respiratory, what is the metabolic compensation? If it is fully compensated, it is a single acid-base disorder. If it is not compensated, if there is no compensation, it means there is mixed acid-base disturbance. Okay? Mixed acid-base disturbance can be 2 or 3 processes can be present. There can be triple acid-base disturbance. That is step 3, okay, compensation. Step 4 is, if there is metabolic acidosis, should look for anion gap. Anion gap is high or normal. Step 4 is, with metabolic acidosis case, look for anion gap, whether it is high or normal. If it is high anion gap, look for those 4 causes. Check delta ratio, look for those 4 causes: cult, ketoacidosis, uremia, lactic acidosis or toxins. If it is normal anion gap metabolic acidosis, look for 2 important causes: diarrhea and renal tubular acidosis. Okay? If it is metabolic alkalosis case, next we should look for urine chloride levels. We should know whether it is chloride responsive or chloride non-responsive. If it is a classical case of metabolic alkalosis, we should look for urine chloride levels. Mainly, we should know whether it is chloride responsive or not. If it is a respiratory acidosis case or respiratory alkalosis case, we should know whether it is acute process or chronic process or acute and chronic process. Okay? What is step 1? Acidemia or alkalemia. Step 2, primary acid-base disturbance, metabolic or respiratory. Step 3, compensation. Step 4, if it is metabolic acidosis, check anion gap. If there is high anion gap metabolic acidosis, check delta ratio. Look for delta ratio. Delta ratio should be 1. If it is more than 2, means there is additional metabolic alkalosis process. If it is less than 1, we should look for additional normal anion gap metabolic acidosis. Okay? A 25-year-old patient with pain abdomen, vomiting, with multiple seizures, no history of fever, head injury, non-smoker, admission, skin was cold, clammy, pulses not palpable, BP not recordable, bilateral course clips. So, ABG showed severe acidosis, metabolic acidosis, bicarb 5, pH 6.8 is metabolic acidosis, the hypoxia. What about anion gap? Sodium minus chloride plus bicarb. Sodium is 151, chloride plus bicarb 96 plus 5 means 101, 151 minus 101, high anion gap. Okay? The high anion gap metabolic acidosis case. The patient was intubated and put on ventilator support, IV fluids, dopamine, noradrenaline, phenytoin was given. The other parameters, mild renal insufficiency, liver function is also mild elevation of SGOT and SGPT, normal bilirubin. So, repeated ABG showed persistent acidosis with low serum bicarb, no improvement in BP general condition, patient died on 3rd day of admission. Actually, retrospective data showed it is a treatable cause. Ketones are normal. To rule out toxemia, what we should do? We discussed 4 steps. Anion gap was checked. There is high anion gap. There is high anion gap. Delta ratio was checked. Then we should look for osmolality. The next step is, there is high anion gap, but there is no evidence of ketoacidosis. Even lactate, there is a mild elevation. Because of probably hypoxia, there is mild lactate elevation. Mild renal insufficiency can't explain this condition. So, ketoacidosis, uremia, lactate. The fourth one is toxins. To diagnose the toxin cause, poison-induced metabolic acidosis, we should check the osmolarity, plasma osmolarity, measured plasma osmolarity and calculated plasma osmolarity. On the day one admission, if we check plasma osmolarity, actually this case is, he took homeopathic medicines for rheumatoid arthritis. Homeopathic medicine last 3 days almost is a 450 ml bottle. We took almost 3 bottles in the last 5 days. Alcohol content 90%. That medicine, it contained ethylene glycol. On the last day, third day, along with ABG, they checked plasma osmolarity and they measured this calculated osmolarity. Serum osmolarity was 360, calculated one is 336. More than 20 is high osmolar gap. Osmolar gap is serum osmolarity minus calculated osmolarity. 360 minus 336. Normal osmolar gap is up to 20. It is more than 20, we should look for toxins. So, there is high osmolar gap. He was using homeopathic medicine which contained ethylene glycol. It is a treatable cause, at least in some cases we can treat ethylene glycol toxicity. How we can manage ethylene glycol toxicity? With pyridoxine thiamine supplementation, we can give fomepizole. Fomepizole is alkyl dehydrogenase inhibitor. Fomepizole alkyl dehydrogenase inhibitor, fomepizole hemodialysis, we can manage ethylene glycol toxicity cases. This is the first case. So, in the step-based approach, if high anion gap is unexplained, if we rule out diabetic cause, lactic acidosis cause and renal cause, we should check for osmolar gap. Osmolar gap. If osmolar gap is more than 20, we should carefully look for toxins. So, the step-phase approach of high anion gap. If there is high anion gap, look for, check ABG to confirm acidosis. Unmeasured anions minus unmeasured cations. If phosphate is more, if phosphate is increased, phosphate is in an unmeasured anion. If phosphate is increased, anion gap will increase. If albumin is increased, anion gap can be increased without acidosis. Okay. So, anion gap can be increased without metabolic acidosis. But in pathological states, like in ketoacidosis, in lactic acidosis and in advanced stages of kidney disease or with toxins, we expect metabolic acidosis along with high anion gap. So, check ABG to confirm presence of acidosis. If there is acidosis, check lactate and ketones. The lactate, evaluate hypoperfusion, check ketones and then check renal function. If we rule out KUL, ketoacidosis and uremia and lactic acidosis, then check osmolar gap. If osmolar gap is more than 20, we should look for toxins. We should screen for toxins. We can screen for toxins in the blood, we can check organic acids in the urine. But if osmolar gap can be less than 20 in certain situations, even with high anion gap. Okay. Case 2, a 61-year-old female presented with acute encephalopathy, ataxia, slurred speech, with history of non-small cell lung cancer, underwent lobectomy, past history of bariatric ileojejunal bypass. She was admitted with neurological findings, with encephalopathy findings, but we will focus on anion gap. There is wide anion gap of 24. Metabolic acidosis 7.15 pH with entirely normal renal function, liver function, normal glucose, no ketones, normal serum osmolarity. And osmolar gap is normal. So, there is high anion gap, but all are normal. So, in KULT, no ketones, no uremic toxins, no evidence of lactic acidosis, no evidence of toxins. What could be the cause? In that situation, even CT, MRI, EEG are normal. In that situation, especially with the past history of bariatric surgery, we should look for short bowel syndrome and accumulation of D-lactic acidosis. Normally we check L-lactate. What we check is L-lactate. But in some situations there can be accumulation of D-lactate, D-lactic acidosis. This is a case of D-lactic acidosis. Patients with D-lactic acidosis can present with recurrent episodes of encephalopathy. So unexplained hagma, we should look for D-lactic acidosis. The case 3, last case. So 33-year-old female with new onset joint pains, intermittent fevers with watery diarrhea. What is the serum chemistry? Even without ABG, with electrolytes, with this sodium chloride bicarb, we can assess anion gap. What is the anion gap? 136 minus chloride plus bicarb, 124. Most fall in the upper limit. So normal anion gap. The normal anion gap, non-anion gap metabolic acidosis, normal anion gap metabolic acidosis. There are mainly two causes, diarrhea or renal tubular acidosis. How to know whether the cause is diarrhea or renal cause? For that we should check urine anion gap. We should check urine anion gap and we should check urine osmolar gap. Urine anion gap equation is urine sodium plus potassium minus chloride. Urine sodium plus urine potassium minus urine chloride is urine anion gap. Urine anion gap will be low in extrarenal cause. Urine anion gap will be more than 1 in renal cause. So in a case of normal anion gap metabolic acidosis, to establish the cause, we should check urine anion gap. Okay. The etiology of normal anion gap metabolic acidosis, the primary issue is loss of bicarb. This is gastrointestinal loss of bicarb and or gain of hydrogen ions. Coming to renal causes, in proximal renal tubular acidosis, again the mechanism is loss of bicarb. In the renal causes, proximal type 2 renal tubular acidosis, mechanism is defective reabsorption of bicarb in the proximal tubule. Again loss of bicarb is the mechanism. And in type 1 cause, distal renal tubular acidosis, and in the type 4 cause, there will be hydrogen accumulation of hydrogen ions. That is the cause for metabolic acidosis. So in type 2 proximal RTA, defective reabsorption of bicarb, so there is bicarb loss. So if there is bicarb loss means chloride accumulation, again hydrogen ions accumulation. So there will be metabolic acidosis. So what are the compensatory mechanisms in kidney? How those extra acids are accumulated? Mainly by ammonia secretion. So in diarrhea, there will be bicarb loss and there is metabolic acidosis, increased hydrogen ions in the blood. So urine acidification mainly occurs through ammonia secretion. There will be increased ammonia synthesis and there will be increased ammonia excretion. Okay. Negative means extrarenal cause. Urine anion gap is positive means renal cause. So kidneys use ammonia to get rid of hydrogen ions. We will discuss about urine anion gap. Urine anion gap is urine sodium plus urine potassium minus urine chloride. Again, here cations are sodium and potassium are measurable cations in the urine. This is ammonia. Usually we won't measure ammonia. In the anions, chloride is the main measurable anion. There are some unmeasured anions. Okay. Normally some ammonia synthesis, but if there is extrarenal loss of bicarb, there is significant metabolic acidosis, there will be increased ammonia synthesis. and increased ammonia excretion in the urine. So, in extrarenal cause, in gastrointestinal loss of bicarb, this ammonia, urine ammonium level will be increased. So, if urine ammonia level increases, so what is urine anion gap? Sodium plus potassium minus chloride. If urine ammonia increases, your anion gap will be negative. So, if urine anion gap is negative, it means there is more ammonia synthesis. There is normal tubular function, normal kidney function. We will remember that one, that single point. If urine ammonia synthesis increase, it means extrarenal cause. If urine ammonia synthesis is compromised, it means renal cause. Okay? In renal cause, urine ammonia production is a defect in ammonia production. Urine anion gap will be positive. Okay? We will close this session now.